Okay, so welcome to 232. This is going to be back to Med Search. They kind of start you guys off with like four different topics all at once, but just keep in mind the second week's a little bit more laid back. It's kind of like leadership and prioritization, delegation. It's a little bit more critical thinking on the questions rather than like purely knowing the content. So you guys can digest everything that's going on here. Um, you have a little bit more time than like a normal week just because of that. Um, I'm gonna try to get through Central Line, Blood, and TPN today. I think I said I was gonna do a session on Sunday, but I'm actually gonna take a night shift today for preceptorship, so I'm probably gonna be asleep at 12:30 tomorrow. So I'm gonna move that to a different day. I'm not sure what would be a good day. In general, I might actually switch the meetings to a little bit later, just so you guys have more time to digest the information because your lecture is on Wednesday, Thursday. I was thinking Tuesday and Wednesday. Is that okay with people? I think there might be like some Tuesdays I can't do, but I'd have to check my little thing. Actually, I can do that on a lot of days. Okay, cool. Well, I'll workshop it through because I'm still tutoring second semester as well. And I think I'm doing theirs on Tuesdays. Um, or on Mondays, actually. I think I'm doing theirs on Mondays. Oh yeah, so Monday doesn't work for you guys. So Tuesday, Wednesday. I think Tuesday, Wednesday should be okay. Yeah, that should be fine. Okay, I'll think about that then. It also gives you guys more time to digest the lecture content because going from lecture on Wednesday, Thursday, and then trying to do questions or outlines like immediately, like 2 days later, probably doesn't give you guys enough time to digest everything. Um, all right. Did you guys get orientated to your clinical sites yet? Cool. All right. Well, hopefully you guys have a decent 232 and then you guys can move on to 240 and make it where we are right now in preceptorship. For those of you guys that went through 220, I think this class is a little bit more laid back comparatively compared to 220 in terms of lecture. So in that class, you had like really long double topics, multiple, like very often throughout the weeks. And in this class, I think there's like maybe one double topic, but it's not that bad. And in general, Mr. Robbins, yeah, I think that also affects it. You guys know how to study better. I recommend highly, very much listening to Mr. Robbins' lecture content. Especially take note of everything that he repeats a lot. So there's going to be some things where he'll repeat a few times. That's like something to keep in mind. Um, I think very much a lot of the content for the exams is based on like how he presents in class. So pay attention in the in lecture stuff as well, things he repeats often. It's always good to keep that in mind. And of course, there's still going to be like some critical thinking questions where like you have to take what you learned in lecture or what he said in lecture, what he said in class, and apply it in specific ways. So I still obviously recommend doing practice questions as much as you can because that's what's going to help long term. Other than that, I would say for anything, just ahead of time, for anything that's not Mr. Robinson's content, Miss Brooks' content, I think tends to be a little bit more of expect the unexpected. So I definitely recommend doing, so especially for like delegation leadership practice, finding questions on prioritization online, Quizlet, whatever. They can get really funky with those. So be careful with that. Yeah. But for this, we're gonna start with Central Line. You guys, I think probably on Wednesday or Thursday or whatever day, maybe Monday even, got to work a little bit with the Central Line dress changing. That's gonna be one of your CPEs. I think this one CPE after, I think after your main one. I can't remember the order. I don't know if you do this one first or the other one first. Your scenario. I think you do scenario one. Scenario was earlier than I think, like week 3 or 4. Yeah. Okay. Okay, so you do that CPE later and then your scenario one. Yeah. So what we're also gonna do is we're gonna do mock scenarios in Skills Lab to try to put that pressure, same pressure on you guys. Something similar. Again, I think something they might have even made you do is like sign something like acknowledging that environmental assessment. You read the environmental assessment policy and the guidelines and stuff like that, maybe. They made our semester do that. It's kind of like letting you know that environmental assessment is a really big deal, and your instructors will be very critical of your environmental assessment, or at least some more than others. But in general, that's a thing to take into account, especially for the CPE. So just keep in mind when you come to the room, is what is expected from report actually there? Do you need to act like maybe the SCDs are on, but it's not actually turned on? Patient is supposed to be on nasal cannula, but nasal cannula is nowhere to be found. Patient has seizure precautions, but the side rails aren't padded. There's no suction um, at the bedside ready. There's no O2 nasal cannula at the bedside ready just in case. All these things to keep in mind if there's supposed to be a Foley in report, make sure there's a Foley, or you didn't get a Foley in report, but you checked to see like maybe they placed one without letting you know for some reason, or you just make sure like you're not coming back into the room and with your teacher, and they're like, oh, there's something hanging that wasn't in report, and you're like, oh, whoops, or it's like, oh, there's a Foley, you didn't tell me there was a Foley. Things to keep in mind. So you don't want to be that person there. And then I would also recommend it becomes sometimes common for people to keep in mind like their medications for that they're going to pass out. So maybe like, oh, I'm doing AM meds or PM meds or whatever. And they only like take note of the medications that they're going to pass. And then something comes up is like, oh, the patient's nauseous. Or what medication is on their MAR for PRN nausea? And you're like, oh, I didn't write that down, So keep in mind PRNs as well. Those are some of the things that you can do or you can give out based on your assessment and stuff. All right. So other than that, we can start with the actual lecture part of it. Right now, I'm gonna start with like a peripheral IV review. So this is something we should all know by now or be making sure that we're familiar with. So your peripheral IVs, I want to see if you guys can tell me what you guys know about 18, 20, 22 gauge, like what color, what's it typically used for, all of that stuff. So just drop in the chat or you can say out loud um, in regards to this. Make sure that you guys know how to tell these apart, understand what they're used for, or understand when it's not appropriate to have one over the other. Yeah, so 18 is a green. That's the green color. It's good for blood transfusion, um, for sure. It's also good for some other things. Can you guys think about what you might want um, an 18 gauge or for as well? Think about what an 18 gauge is. It's a big catheter. Yeah, exactly. Like high infusion of stuff. TPN, yeah. I think TPN on PIVs typically no, you don't want to put TPN in a peripheral. You can for like a limited amount of time. Maybe PPN you can through peripheral, but TPN you don't want to have it in the PIV for too long. You want to switch to a central line when you can. Pretty much anything, yeah, like a high flow of IB fluids. So something to think about is patient on seizure precautions probably wants to have two large bore IVs because if they ha have a seizure and the seizure doesn't stop, or they have multiple seizures in like a 5 minute span. Do you guys remember what that's called? Continuous seizure that doesn't stop, or they have a multiple seizures in a short span. Yeah, the status epilepticus. They want to have the big gauge so that you can do rescue IV fluids or rescue IV meds as well, so you can decrease the risk of some complications like speech shock where you're going too fast. It's too much for the catheter. Um, so that's good. And why would you want to have two IVs in the scenario of blood transfusion or the scenario of rescue fluids or rescue meds? Why would you want to have two IVs? Yeah, so these are all good answers here. There's a few reasons for why you might want to have two IVs in case, like Annalise mentioned, if you blow a line. So if a line doesn't work, like imagine like someone in an emergency situation, they need like rescue medication, right? And then you find out that their one IV isn't working anymore. Well, even it was for like rescue IV bolus or something, you'd have to spend that time putting another IV in, and you're wasting like valuable time that they're not getting what they need. So it's going to be for safety reasons. But then now imagine like a seizure patient. Imagine someone having status epilepticus, so they're constantly seizing. Imagine trying to place an IV in them while they're having seizures, tonic-clonic seizures, because you didn't check that there was two IVs prior. So think about like what would happen in that situation, how hard it would be to place another IV if the second one blew. Um, so that's why you want to do it. It's just more safety. It's used for emergencies, or maybe they're running something continuous, like Nydia mentioned, like compatibility as well. So if they need to have some sort of drip or something infusing, um, and then also need like a blood transfusion. A lot of the blood is not compatible with anything other than NS. So if they're getting something else on the other line, they can have that second line there to run the blood or something like that. And then I'm seeing Ryan. Yeah, if they have a reaction, you also want another IV site. You're gonna want to disconnect or this. You want to stop the blood. Um, See if you have the second IV site access. You want to give them a lot of IV fluids. You want to have that extra NS available to give. So yeah, all of these are really good answers. Um, so kind of right down here, we kind of talked about blood transfusion for large bore, rapid infusion. Talked about multiple IBs in the case that one no longer works. Multiple medications are needed at once. Yeah, so all that's good. What about 20? What color is 20? Yeah, this one's pink. It's pretty much used for the same stuff as the 18 gauge. When it comes to like the large bore, if you can put the 18, that's better. But some people like the veins, it's gonna be harder to place the 18, it's bigger into the vein. So if they need a large bore, but the 18 might be too big for the vein, then you can put a 20 in. What about your 22 color? This is the blue. Yeah, this one's blue. It's kind of like your standard IV when emergency situations are not really expected. Easier to place on people. And then your 24, what color? What's the general use case for this? Yeah, this one's yellow. And this one's kind of used for, let's see if you guys remember that. Oh, I was like pets. Yeah, for children, maybe some older adults, maybe people with weaker veins or smaller veins. And also in the same idea where you would not be expecting an emergency because with the 24 it's too small, so you can't put blood through it. You can't rapid infusion might might um cause speed shock or like destroy the catheter or kill the access. Um and um and why do you need a big catheter for blood transfusion? To prevent clotting, consistency of the blood. I think you guys are along the right track. And let's see if someone comes up with the exact thing I'm looking for. It's along the right track for sure, but um that's one of the reasons for sure. You can allow a higher flow rate. It's one more reason. So think about the gauges. As you go down in number of gauges, they're bigger. Has anyone seen or had a blood draw where the potassium was abnormally high, like 8 or higher, and you find out that it was, they call it hemolyzed, where there was an error during the blood draw. Does anyone know what I'm referring to? So the idea would be that the bigger gauge, um, it's big enough that it's okay, yeah. It's big enough so that the blood cells don't burst. So if you do a blood draw incorrectly with the wrong technique or you do it too fast, sometimes those blood cells from the blood draw can burst. So you get abnormally high potassium when they actually do the labs. So sometimes the potassium being 8 on the blood lab might actually be that the blood lysed, it bursted from the technique. So that 8 is not actually an 8. So you'd have to get another blood draw. And then kind of the same idea here. The gauge, if it's too big, in terms of if it's 22 or 24, the actual catheter is too small, so it might burst the blood cells. So what good is giving blood if we're giving them bursted blood cells? So if it's too small, then the blood cells burst and don't actually help you in that scenario. In fact, you might actually even lead to um, maybe giving them a little bit of like hyperkalemia because you're giving them bursted red blood cells. And just like in rhabdomyolysis and just like with that hemolyzed blood draw, you have that potassium being bursted out of the cells, if that makes sense. So let me see what Ryan said. Yeah. So yeah, you had that happen. So when they were taking your blood, the technique was in such a way that it bursted the cells and caused the potassium to leak out from the blood. Yeah, so that's that's funny actually. That's hilarious. But yeah, so that's kind of the general idea behind that. I guess I can try to write some of that. Blood transfusion. All right, so that kind of goes with same thing with the 20. All right. And then what about aspiration and flushing? So when you guys are doing like a flush, let's say you do a flush every shift. I think he went over with this. He probably went over this with you guys. I think he might have even shared like a story about something that happened to him when he was in practice. When it comes to like your flush, yeah, it's per policy pretty much. But I think he really like for him, his own personal experience, he like emphasized that he doesn't like it when like you aspirate and you get no blood return. It could be because what could that be a sign of? And then also when it's difficult to flush. Yeah, it could be a sign of a clot. So you don't want to force it. Why do you think you don't want to force the flush if you're having difficulty? Yeah, you're gonna dislodge it. So that might cause like an embolus and stuff. Yeah, so you can blow the catheter, but even more importantly, you can actually dislodge the clot, and then that's, not a good thing. You would effectively you have that in your vein. So if you have a clot originating from your vein, that's then going getting dislodged. Where do you think that goes? What other conditions do you guys think about with vein getting dis yeah, yeah, pulmonary embolism. Exactly. So that's a potential thing that can happen. Awesome. So we talked a little bit about this. So for what conditions would you want multiple IVs? Think a lot of this makes sense. So maybe you can say seizures, shock. Well, actually, I read this in the wrong place, but that's probably more here. Split it up in a weird way, but blood transfusion or confusion. Boom. Seizure shock. Multiple meds are needed at once. We pretty much. Just kind of think about. You don't have to be like, oh, I have to memorize this list of things or anything. Just kind of think about what are some things that um patients at risk of emergency situations, kind of just cluster it down to like emergency situations. And someone is at a risk of having some sort of emergency based on their condition, like hemorrhagic shock, hypovolemic shock, seizure, then or they need blood transfusion. All of these things are things that if your IV is not working, you're going to need to place another one. Then you just save yourself the trouble and have a second one there for emergency situation. Or if they need rescue medications given quickly, what are some are we going to want a large bore so that we can infuse it quickly? So you can kind of cluster it down into like that concept. Okay. So what are some complications? This is kind of a review from earlier semesters. You can just quickly like mention them. I know you guys know them. Yeah, thrombophlebitis. What else? Kind of like phlebitis, thrombophlebitis, infiltration, extravasation. Yeah, so you guys know to assess that as part of your physical assessment. You're coming in, you're checking the patient's wristband. You're being like, hey, let me look at your IV, assess for that red hard vein for the phlebitis, and checking to see if there's edema in the area, if it's feeling cold to the touch. For infiltration, extravasation is basically infiltration with a vesicant and a very irritating medication. It can lead to necrosis. So you guys, um, I'm not sure if you guys remember what it looks like, but I'll just do it just so you guys see it. Very crazy stuff here. Very yummy right here. All the stuff that can happen. Oh, that's bad. Oh, but yeah, I'm sure if it gets to that point, you'll definitely know, but that's why you want to be attentive because you can prevent it. You can try to prevent it from getting to that point. And I will add some of the information, just kind of talk about it in a little bit once I find my place. But has anyone actually had a patient with phlebitis in the hospital? I've actually never seen it in the hospital. Just infiltration. Wow. I think actually maybe I've seen infiltration actually. I remember, yeah, seeing it. I think there was like active leaking of the fluids into the IV. Um, I think it took a few hours for the nurse to actually change it, but it's okay. So with thrombophlebitis or just phlebitis in general, you have that red, hard cord-like vein. So what are your interventions there? You're going to want to stop the infusion. That's going to be your general thing. You're going to want to stop the infusion. What's the thing that's causing it to have all these things? It's going to be the infusion. So you're going to stop the infusion. The next thing is kind of up to policy. So you're either going to apply cold or warm compress, um, up to policy. I think based on the school, they tell us cold compress to or because you don't know if it's a thrombophlebitis or just a normal phlebitis. They tell you like, you can do cold to try to keep the clot from moving. So Ryan and Josh say it depends on type of solution. Sure, like up to pretty much just like up to whatever the policy for that is. Uh, uh, uh. For infiltration, same thing. You're gonna want to stop. Yeah, you want to stop infusion. You're going to elevate the arm to increase venous return. If it's infiltration with, like an IV fluid, like a normal saline, then just trying to get that kind of drained back to the core is fine. Um, and you can restart the IV in a different area. You can also do by the book, I think that you can do like a warm compress with the idea to increase circulation, try to get um that fluid absorbed into the system. If it's like normal IV fluids that you would want in there anyways. With extravasation, you're gonna also want to stop infusion. You can use the port, so you don't want to stop. So a lot of these you can restart the IV, or with this one, you can also stop the infusion, um, DC IV and stuff. Yeah, you don't want to DC the IV immediately because there could be an antidote. Can use the IV you can aspirate and or yeah, exactly. Aspirate and or provide antidote. Usually when you have this, you can get the antidote from like the rapid response team, I suppose. Um, and then after that's kind of dealt with, you can um move on from there. Some extra stuff that I have, like a hematoma, it's like the bruise, kind of like it can be hard feeling, it can be tender. You can remove the IV, you can apply pressure to stop the bleeding, and insert a new IV. We talked about this a few times, the speed shock, because comes from fluids going in too fast. It can happen from IV pushes that you'll do later on in next semester, pushing too fast. Yeah, like vasopressin. Yeah, so for I like that the autocorrect changed it to reggaeton. That's funny. Just like pushing too fast, especially with like IV push. So you can have some signs and symptoms. I think this is a little extra information, but just for you guys, we're gonna include it. Okay. So now we're gonna move on to central lines. Hmm. So what are some reasons to insert a central line? Yeah, so high osmolarity. So well, high osmolarity can include things like TPN. That's high osmolarity, low pH fluids. So that can be a lot of vesicants. Yeah, long-term IV um, need. What else might be good for that? So kind of it covers a lot of stuff. Yeah, kind of goes along with that. So like chemotherapy, um, you see to home with antibiotics and stuff as well. Um, but maybe they give like a pick line. Yeah, and the long-term IV can be, yeah, heart stick. So I've actually seen that. I had a patient, they got the Doppler out. Um, a nurse tried 2 times. I think the policy was you try 2 times, pass it on. So it was try 2 times, pass it on. Second nurse, try 2 times, and then once you fail 4 times, they call someone to put a central line in at Lakewood. So yeah, difficult stick. Um, that can happen as well. It's a pretty good amount. So they have the different types, the non-tunnel, the tunnel, the PICC line, the implanted. These are central lines that you can see in the skills lab. They have like a little um like half chest person in like somewhere in like the corner of the room where you guys log in. You can see the different types of central lines there. The non-tunnel, that's gonna be the one. I think some of the mannequins have, like on the beds, have a non-tunnel. They have the one on like the right subclavian with the tunneled one. I think that one's on one of the ones that have the like the half chest. Oh yeah, yeah. I'll show it to you guys on next Thursday. You can actually on there you can feel like the tunneling on the thing. It has. I don't think we have a Does he have a pick line? He might have a pick line, can't remember, but he does have an implanted, so you can actually peel his chest and see the implanted port there. Um, with this stuff, I guess there's a lot actually to kind of write here. And I don't want to take too long for it, so we'll just kind of I'll include this little picture here because it's a big picture, but kind of gets the idea of what it kind of looks like. You'll have the non-tunneled central line sticking out like that. You'll have the tunneled. It's going to be inserted in the same area, but it's going to be surgically placed below the subcutaneous fat and then have like a little exit site here. Here it has some case for why you would use one over the other. So with your non-tunneled, um, they might place that as like an emergency one. So out of all of them, non-tunneled is probably the one that last is used for the least amount of time because it's usually meant to be placed like for emergency. Yeah, so I'll write that down here. See here. Where's it typically inserted? I kind of mentioned it already. See if you guys remember. Yeah, the subclavian. And there's some issues when it comes to the things going into the subclavian. I'm sure you guys know uh, a lot about that. There's a high risk for infection. There's a risk of, yeah, pneumothorax. Pretty much in general, you guys can kind of cluster down the idea that with all the central lines, you're going to want a chest x-ray. For a lot of them, it's because of pneumothorax and then also just positioning. So um, yeah, the confirmed placement as well. It kind of hits two birds with one stone kind of thing. So it typically inserted to the subclavian. Um, some advantages. is that there's no surgery. Just the patient just kind of inserts it. Um, so it's preferred for short-term emergent scenarios, critical care. It's not going to be there for as long compared to the other ones. So I think Josh mentioned like days to a week. So like days to weeks, like days to weeks, like a smaller amount of time, definitely compared to the other one. Certified nurse can remove true. And let's talk about that actually. So how do you want to DC it? I think this is going to be important to know. If you are DCing a central line in general, what are you like thinking about for yeah, so the Valsalva maneuver that can be bearing down and stuff to prevent yeah, that's your main focus is you want to prevent air embolism. So just like Ryan mentioned is have the patient lay flat. You can tell them to hold their breath and bear down, so that's the Valsalva. That's important. See if they've mentioned anything about I don't really have anything about pain meds for that. I think it's probably don't really feel it. And yeah, yeah, that's like a thing. He's specific. Oh, no laughing and talking. Basically, yeah, hold your breath, don't talk, bear down, and then rapidly pull out the catheter to prevent the air embolism. What is what called? Oh, the Valsalva maneuver? Probably spelled it wrong. Valsalva. Pressure, measure central venous pressure. Um, the CVP, are you thinking about an A line with that? Not the A line, sorry, the well, I guess it kind of is kind of part of the Swan scans catheter. I think that one typically goes in the jugular though, the Swan scans. But that's something you learn in critical care next semester, so don't worry about that right now. Let's see. That's pretty much it. Once in position, you just want to rapidly pull it out. Yeah. And then I just want to give you guys some symptoms of air embolism. You mentioned this risk of pneumothorax. So, what are some signs and symptoms of air embolism while we're here? And yeah, you mentioned don't laugh, don't talk. Kind of goes with this as well. Yeah, shortness of breath, chest pain. They kind of called it like distant, diminished lung sounds, like sudden tachycardia. Some it's very similar to like some of your pneumo. Yeah, that makes sense. Yeah, kind of all this stuff here. Just kind of understand that. So we talked about some of the advantages, some of the disadvantages, and for when it comes to this, try not to get I think too lost in like the sauce of the advantages and disadvantages. We're just kind of doing this for learning wise, like understanding why, but a lot of like your questions, they're not going to be like asking. I don't think they're going to really get questions on like why this one's better than the other. Just like understanding like why it's used and stuff. Some of the risk factors, like you need to make sure you know you to get a chest X-ray. Um, you need to know you to do a chest X-ray. You need to know about the proper way to prevent air embolism while DCing it. You need to know your sensitive air embolism. And other than that, though, it's not as much like knowing the hyper specifics of it. So I'm just gonna go through and just talk about it. So not for long term, high risk of infection. Yeah, daily flushes. You mentioned like the risk of pneumothorax. Yeah, that could be an advantage, yeah. But just good to know, but not have to hard memorize. You definitely need I think you definitely need to know this. Definitely understand this. The fact that having it placed in the subclavian increases the risk of oh, that's what you meant. Well, it is also easily removed in terms of yeah, it's a shorter line. Well, it's shorter than the rest. Yeah, I see what you're saying. But it technically is. It's kind of like a both an advantage and a disadvantage, because compared to like a tunneled, you don't have to for a tunnel to get rid of that one. You need surgery. It's placed with surgery. It's removed with surgery. Implanted, same thing. Um, so I guess it's both a good thing and a bad thing. So it kind of goes with that. Okay, so then moving on to the tunnel we saw there from the picture. So it's really not all that different. It's kind of inserted in the same way. It's just kind of longer. It's a longer catheter. It's going to be yeah placed surgically so that it's tunneled under the subcutaneous. Yeah, you're not going to pull this one out. You're going to need surgery to pull that. So that's an advantage. But again, don't focus too much on memorizing this stuff here for this. Just think about the big picture. What's the big picture? It's this. This is the big picture. Pneumothorax is a high risk. You need a chest X-ray. Think about air embolism. That's a thing to focus on. And here is just kind of for your own knowledge and understanding of it. So yeah, a long term, harder to pull out. Pretty much, you're not gonna pull it out. You can also say that it's a barrier. The subcutaneous fat is a provides a barrier for protection against infection. So less infection risk than the tunneled. Some disadvantages for it is that it requires an invasive surgery to place and remove. You still need to do routine flushes. And you can argue that yeah, Arn can't remove it. You can argue also that you can have some cell like body images. Like what would you call that? Like body image issues. So some people might not like it because it makes them look like you'll see what it looks like in the skills lab. It's not I don't think it's that bad, but yeah, it's visible outside the chest. Yeah, it makes people feel some sort of way. That's the main thing. Again, just the main thing I think probably this and this for this. This one's longer term, so just keep that in mind. And for this one, this I keep coming back to this. You're gonna need to know this 100%. If any, yeah, you're gonna need to know this. So same thing though, with this one, I guess you will also need to understand that this is also still inserted in the subclavian, so you're gonna need to know this part here. I think yeah, it's pretty much that. Moving on to the PICC line. So when it comes to the PICC line, what do you guys know about it? We can also break it down to like advantages, disadvantages, but again, this is just a lot of that is for your knowledge. I'll highlight the ones that I think are important to know. Yeah, so this one's kind of like for short to intermediate. They can be left longer term, but also not as long. Yes. So yeah. Yeah, so that's because of that, then you're gonna have an advantage of that is that um there's no risk of complications related to pneumothorax due to the insertion, the fact that it's inserted in inserted through the peripheral, which is why it's called a PICC line, peripherally inserted central catheter. You can say it's not inserted through invasive surgery. You can also kind of remove it decently. More risk for thrombophlebitis. Yes. So, and what do you want to do about that? What's something you can do to not prevent so much, but to assess it? Yeah. How would you do that? There's something he specifically mentions that you could do to kind of have a base, like to establish a baseline and to see changes. See if you guys remember that. Yeah, you do want to be flushing and stuff. Yeah. So yeah, basically what I was looking for was measuring, just like you guys mentioned there. So you can measure the size of the arm. We I hate when I click that. Oh, okay. Measure the size of the arm to assess for clot. So if you have increased circumference in the arm, it could be a sign that maybe there's a clot forming. Kind of like when someone has a DVT, you can see unilateral swelling of the calf. So it's kind of like the same concept there. So what's a precaution you're gonna, God damn it, what's a precaution you're gonna want to take? Someone has a PICC line. So this is peripherally inserted. And if you've had a patient with a PICC line, there might be like posters posted like above their bed letting you know about it. Some contraindications. Yeah, but both Ryan and Annalise are correct on that. So you're not gonna want any blood pressure cuffs pressing down on it. So no BP in the arm. And just like Ryan mentioned, you're gonna want to minimize the amount of stress movement on the arm. What else? Yeah, so not so much mobility and definitely no heavy lifting. I spelled lifting wrong. Oop. What else? Let me see. Yeah, no blood draws either. Well, if you're gonna do blood draws, I think you can just just double check on that. You can just grab. So you don't want to do a Benny puncture, but you can just draw. You can draw the blood from the PICC line in that scenario. As long as you're doing the blood draw with so if you guys know for your central line, the PICC line that you guys used to practice on the central line dressing has different gauges. So you can do the blood draw on like like the 18 gauge. Sometimes they have 16 gauge. So like you could do it on try doing it on the bigger gauge, bigger as in like bigger size. So like a 16. Okay. And do we want a chest X-ray for this one? Yeah. So you still want a chest X-ray, except for this one, it's just to confirm placement. So you're gonna want a chest X-ray on all of them just to confirm placement and also to see if there's a um, probably just specify. So all those are same thing here and same thing here. So that's important to know. You still do a chest X-ray for this to confirm the placement. Um, this is a big deal. I think know this and definitely know this. So then the implanted port, I think, is not as emphasized as much. So I'll just kind of quickly go over it. Main advantages is that it can be functional for many years. It's completely under the skin. It's lower maintenance. Your flushing it is maybe like every 4 to 6 weeks with heparin. No need for a dressing. The disadvantage is it's gonna be surgery to insert and remove. Need the Huber needle, the non-coring Huber needle to access, which is a sterile process. Mm, yeah, the Huber needle can stay in there for a little bit. Let me see exactly how long. Yeah, 7 days, it says. Okay. He does talk about the Grosjean catheter. I don't think I really wrote about it, but the idea behind it is that it's essentially a three-way valve, so you don't have to clamp anything with the Grosjean. Um, I'll kind of just include a picture. So the idea would be the catheter, the valve can tell when when things are connected or not, and kind of change its pressure accordingly. So there's no need to clamp. So it would just be, yeah, you don't want to clamp it with this one. So that's the main thing you want to know about it is that with the Grosjean three-way valve catheter, three-way valve, you don't need to clamp because it will yeah, so exactly. So it provides its own pressure as based on what you're using it for automatically. So you don't have to, you just insert, deconnect, and it will automatically apply the appropriate pressure for what you need to do. So that's that. Complications, we already talked about pneumothorax. Um, Obviously CLABSI is a big thing. So CLABSI, I'm gonna try to get us to blood as fast as possible, but typically 2 to 3 days after insertion. So in general, like even like after like a surgery, like your post-op, the if you have a fever or it's a little bit swollen or red, um, that can be normal up until like a certain point when and at that point that's when you start thinking about like infection. With this one, the clap similar idea. It's still like 2 to 3 days after. Um, if it's like if you do have a fever the same day that you inserted central line, it's probably not related to the central line. It could be some sort of other infection or something else happening that's causing the fever. So that's something to keep in mind. And obviously, you're going to want to have that aseptic technique. And I think in this class, he gives you guys a little acronym for it. So let's see if I can get that down. Scrupulous, the scrupulous. So we'll go here. So scrupulous hand hygiene, aseptic technique. Make sure you're scrubbing the hub properly. Everything's patent or whatever. And I'll give you guys also a table that has all this stuff and maybe a little bit extra stuff just to give you guys a bunch of information that you need. Some other things that we've been talking about this, so I know you guys know occlusion or clots are things. We've been talking about it for a while now. Um, Accidental removal. So, um, malposition. Okay, and then we talked about the air embolism. We talked about the signs and symptoms. So how do you intervene if someone is having air embolism? What would you want to do? Exactly. So you're gonna want the patient in Trendelenburg, patient lie flat on the left side, and this causes the air that would be like the embolism that's in there to be trapped in the apex of the ventricle. That's kind of the idea, so that it can't reach the lungs. And then obviously you would call for help, more hands on deck. So this is important to know. You guys should know your intervention for that. So some considerations in patient education. Again, chest X-ray always. To confirm placement and or assess for pneumothorax. So always want to think about that. What else do you, this is part of your CPE for the dressing change. When it comes to like assessing the catheter, what's something you want to document, something you always want a septic technique, of course. What else? So, yes, and why is that important? Yeah. So what happens if the catheter has been pulled into it? So it's like there's less external. Are you able to if the catheter is pulled out a little bit, what can we do? Can we push it back in? No, exactly. Yeah, you don't want to do that. You're essentially it's like you're double dipping your chip or something. Yeah, we can pull it out. Yes. So that's yeah, like Ryan mentioned, we can pull it out, but never in. So our pull-out game is strong, so we can do it. Then we can talk about the dressing changes. This is kind of just like go over your review for how to how to do the um yeah, so like every 4 to 7 per policy. I think he kind of emphasized more 7, but yeah, Q 4 to 7 days or per policy. Um Stuff your basically this is basically your CPE. So I know you guys know this. I'm just gonna copy paste all basically your steps. Um or a PRN if it looks soiled or whatever. So this is kind of like all the steps for your CPE is checking the allergies, i.e. the patient, you're setting everything up, assess the site and catheter. Um, I don't know why it says type. I guess that was supposed to be filled out. I'm just gonna close that. Uh, at the start, you're gonna use clean gloves at the start, um, to assess, just like your normal gloves to assess, and then remove the old dressing. And then afterwards, you're gonna want to then put in your sterile gloves. You want to do things aseptically. So he emphasized that, and I'll emphasize that again. When you're doing your dressing change, we are not using clean gloves on the actual change. We are using sterile gloves. Okay? Does that make sense? You guys got that? So we're not using clean gloves for, yeah, we're not using clean gloves for the actual dressing change, only for like the initial assessment and to remove it, only to undress, yeah. But we're using sterile gloves. So he literally told you guys, he tells everyone that every time, and people still like to click the clean glove one. So just keep that in mind. He said it. He said it. He said it like at least once or twice. Yeah, you're gonna clean with chlorhexidine, all that good stuff. Oopsies. Where are we at? Okay, so we're finally over to blood. Is there any questions on central lines or PIV? Okay. So kind of quickly talk about compatibility. I know you guys know this. We've been talking about it, the large bore. So that's why I wanted to go over central line first, because central line kind of is understanding that is key, before talking about TPN and talking about blood. So large bore, we said that's 18, 20 gauge or whatever, or smaller, as in like 16 or 14. But these are the two more common ones, is 18 and 20 gauge. What about IB fluids? I know Nydia mentioned it, but let's see if you guys remember, as a collective. Yeah, exactly. So you're only compatible with NS. What about D5 NS? Does that count? Yep, exactly. So only be ran with exactly NS. No D5 NS, no half NS, exactly NS. And why is that the case? Like, what happens if you run it with D5 NS? Not a trick question, just like think about your compatibility in general. Close, like clumping and stuff. Kind of. Just honestly, it's the same idea behind why you want to check your secondary IV. Um, or your secondary with your primary compatibility. Because what can happen? It can cause clumping and crystallization. So it can it can cause precipitation, crystallization. Um, so that's the reason why we check compatibility with the secondary. It's the same idea with the blood. Um, in general, in D5NS's case, it's probably more the clumping, but in The others, it's can even lead to like the crystallization of precipitation and stuff. But probably in general, it's probably more about the clumping, honestly. But in the future, when you guys get asked about compatibility in your Kaplan or something, just know that the reason we check compatibility is can include crystallization and stuff. So for the blood types, actually one more thing. I was gonna give you guys something. Hold on. Ba, ba, ba. For central line, I have this little table. Let me increase the size so you guys can see it better. So this table here, just a complication of your CVAD stuff. So a lot of this can be a little bit extra, but it's all in like a little table in one place. So I hope that helps. And yeah, back to this blood types. I'm going to provide you guys. Um, you're going to need to understand the compatibility. I'm gonna have a table for you guys. If you guys are, it's a little too big, I guess. Do we all understand how blood type compatibility works? So I know some people struggle with it a little bit. The table should help. It's like the Crips versus the Bloods. So the A is the Crips. If they see the Bloods, they will kill them. And this is like a double agent. He's not gonna do nothing. So he can accept everything. And then this guy's a cop. All right, we go. He'll kill all of them, I guess. O for cop. Okay. I hope that helps. If not, I literally just came up with it. So, but yeah, they will attack the one that it's not. AB because it's both will accept all of them, and O because it's neither will reject all of them. And there's also like an RH factor. You guys remember from OB and pediatrics. Um, and you're not going to be asked hyper specific question on all this, just kind of get the general idea. So the general idea is you either have it or you don't. It's like an extra little antigen. If someone is Rh positive, then they can receive both positive and negative blood. So if they have it, they attack. They attack. They don't attack anything because it accepts other Rh positives. And if you don't have it, just like kind of like the O, um, it can. Do you see the other ones here can accept O? Everything can accept O. When you don't have an antigen, it's like you're a neutral party. You'll accept it. But if you are Rh negative, then you see someone come in with that extra Rh antigen, and then you start attacking it. But it's worth noting that if you guys remember from OB, that on the first exposure, you actually have no reaction. So initially, you don't have a reaction. So if an Rh negative person receives positive blood or has a baby with a positive Rh father, they will develop antibodies against Rh, but on that initial exposure, nothing will happen. But the second exposure will result in a reaction. Does that make sense? Cool. Alrighty. So what is the criteria like the main criteria that people look at for to determine if they need blood or not. Did I mention it has to be compatible? Yeah, I mean, I'm sure that makes sense, but yeah, so HEB of less than 9 is when they will consider it. Realistically, you'll see a lot of places won't give it until under 7, but you're able to give it under 9. Okay. Uh, you must be ABO compatible. So that needs to be something that is done because otherwise it's not safe with the blood. Well, I guess this is more for like prescription, but just keep that in mind. And then in terms of assessing for the effectiveness of the treatment, um, what's like I'm sure you guys went over this, but if you were to give 1 unit of blood, what can we expect to see improvement in the H&H? Yep, exactly. So 1 unit of packed red blood cells is equal to an increase of 1 hemoglobin, and that ratio is approximately um, 3x for hematocrit. So every unit, um, you're doing it like that. So expect a question that requires you to do this. So expect to have to know this. If not for the immediate test that you have it here, but for the final, just expect to be have to know this. And here is just kind of quick review of anemia. So some signs and symptoms. I'll just kind of write it out. You guys know it by now. Fatigue is your most common symptom. You can have paleness. You can have weakness because, of course, what does your red blood cells do? They pass along oxygen to the cells. So if you don't have oxygen to the cells, you're not gonna have the energy to do things. Tachycardia because of compensation. So if your body is struggling to get um, good perfusion because there's less red blood cells, less percentage of red blood cells going around. There's less oxygen, there's less energy. Your body compensates by increasing the heart rate to kind of get more blood circulating, to get more oxygen circulating. Low blood pressure and weak pulses makes sense that if you have less of everything kind of going in, um, you're gonna have maybe like a fast, thready pulse, lower blood pressure. A headache makes sense because your brain doesn't have any reserve for oxygen. So if your body is struggling to get as much O2 because of the anemia, then you can have headaches because it's starting to um, affect the brain. You're kind of not giving it enough O2 and whatnot. Chest pain, same idea. You can have chest pain when there's not enough blood to the myocardium. Um, same kind of idea. And obviously, as it progresses and keeps lowering and lowering, the symptoms will get worse, or sometimes the compensation will fail. So maybe instead of your tachycardia, you could have bradycardia as like a very late stage sign because your bodies can't compensate anymore. But as a nurse assessing the patient, you're gonna see tachycardia initially unless you are in like the emergency room and they're decomp or ICU decompensating or ER even, I guess, and bad things are happening. Okay, and then here it's just kind of like a list of people for who surgery, blood transfusion would be good for. So people with anemia, of course, people after surgery with their hemoglobin being low, trauma, people with chronic kidney disease, people with sickle cell disease or sickle cell crisis, or I guess just disease in general. Let's just put sickle cell. Some of the things, why does chronic kidney disease lead to anemia? And is blood transfusion the first line for people with symptomatic anemia? Yeah, so the reason for that is because your kidneys are produce erythropoietin, and erythropoietin stimulates your bone marrow to produce red blood cell. Um, so if you don't have erythropoietin, you don't have that stimulation of your bone marrow. So yes, so you're gonna want to try Epigen first. That's your erythropoietin, synthetic erythropoietin. So you're gonna want to try that first, because if they don't have this, you just give them this. And then the sickle cell, I think he just mentioned, cells only last a certain, like a less amount of time. Don't focus on the numbers, but it's there. This one you should know though. You should know Epigen. Yeah. So let me see what I have on that. Ba-ba-bum. I'll find it in a little bit. Yeah, I'll find out what I had in a little bit. For now, you guys can tell me about autologous blood transfusion. Who would it be appropriate for and why? Or what does it
The
mean?
autologous blood transfusion.
Yeah. Okay. So I have this tweet. Let's just do this. Okay. Here's what I had when it comes to Epigen. I think this is just from your drug book. Yes, autologous, auto as in self, logos as in origin from. So self-donated blood essentially. That's another option. It's like if you know you're going to go into a procedure where you might lose a lot of blood, you can prepare a self-donation essentially a few days prior, allow your blood to replenish, and then
Weeks.
yeah, or weeks, yeah. Um,
Oh, sorry.
but yeah, and then this is what I have on Epigen. So some sinus symptoms, hypertension would be the most common one. Um, again, this is from the book. You don't want to give it if the hemoglobin's too high. It can cause hypertension. Um, this probably like increase ICP too much RBC going around. That's pretty much all I have on it. If you guys have something different, you guys can let me know. All right, any questions so far on this? We're gonna talk about the actual blood transfusion, how to actually go through it, some of the reactions, and then some of the lesser ones. Well, not lesser, but like clearly the chapter's focused on blood more than anything, but you're still gonna have to know the other ones, of course. Okay. Um, so for safe administration, what do you have to ensure prior? What are some things you need to do before you even consider having things go down? Yep. So you're gonna definitely make sure you have consent. So this can be informed consent on paper, but then you can also do a verbal consent before it actually happens. So like someone can sign the informed consent, and I believe they have the ability to still say no, like verbally. Um, Cross match, yes. Type and screen cross. Yep, I spelled screen wrong. So they get a blood ban on the patient. So the patient has a blood ban. You're gonna use that blood ban to do your confirmation on them. The blood and cross is essentially literally checking their blood with the donator blood to see if they would cause a reaction. You're gonna need to do informed consent. You're gonna need an order, of course. Don't give a blood don't give blood transfusion without the order. Educate patient, monitoring. That's fine, yeah. Ask patient if they had reactions in the past. Yeah, that could be good. That could be ask patient if they have had reactions in the past. What else for safety that you are assessing on the actual patient this time? Probably put that in here. I know it can be a little confusing here with that. With this, I kind of want like the direct steps once everything is ready to go and you're just doing the steps. And then here is kind of like things you want to ensure before the whole process even begins. Yeah, you're gonna want a urine specimen. Why do you want the urine specimen? Yep. So it's gonna be you do a urine specimen. If the blood transfusion goes through without any issues, then I believe you don't really do anything with it. But if they have um a reaction, then you're gonna want to take another urine sample and you're gonna compare them to see if there was a hemolysis. A hemolytic reaction would then have hematuria, so there'd be blood in the urine. Um, so I guess how do I word this? Prior, a patient has a reaction, they get another urine specimen, and they are compared to see to assess for hematuria due to a hemolytic reaction. Yeah, it's your baseline. Yeah, just like I called Patrick, like Ryan mentioned, for your baseline urine. Exactly. What else on your actual like on the actual physical patient, do you want to make sure? We talked about this a bit when we were talking about IVs and stuff. Oh yeah. So I asked like, what would you want to check is there on your actual patient? So yeah, Ryan mentioned it is you want to have at least two large bore IVs because otherwise it's not really going to be um as safe. You want to make sure that when you're setting up all your stuff, you're doing it with normal saline only. Yeah. Safe administration, this one's a little bit vague, 'cause, but for the transport and pickup, you need to do it. You must start. When do you must like? What's your time within blank of receiving blood? So this is start. So when you're starting, it's within 30 minutes. Yep. Let's see what else. So let's talk about the yes. So you want to have NS set up. Not so much for TKO. I think they want you to have so they want to have like a bag of NS uh ready to go in case of a reaction. The other one is just kind of there. If you guys remember the Y, like the little blood tubing that they had you practice with, you have it spiked to your blood and you have it spiked to your normal saline. Depending on the policy, um, they'll prime it with the normal saline. Um, first, just to prime it, and then the blood will go through. And then you have a separate bag of NS. And then you can use, and then the one that's connected to the Y tubing, that one's used for flushing between each unit. So Josh says you can use 2 units using the same line if needed. Yeah, not at the same time, but yes, you can each tubing set can be used with up to 2 units of pack red blood cells. And you want to flush with NS between each unit. Have a bag of NS ready. So this is 2 different bags of NS. So you'll have your blood unit, you'll have an NS that's hooked up to the Y port or the Y, not the port, the Y administration set for the blood, and you'll have another bag of NS just in case. The reason you don't use the one that's already connected to the Y administration set, that's hooked up to the blood, is because if you were to stop the blood and then unleash the NS that's hooked up to the bag. Before that NS actually gets into the vein, you're pushing up all the blood that's left in the tube. So you're not going to want to use that one. You're going to want to use the separate NS. So something he mentioned is for patients with congestive heart failure and chronic kidney disease. Well, not so much chronic kidney disease, but you like want to assess for conditions. So chronic kidney disease and congestive heart failure, because they might have different treatments because they have a risk of what? Higher risk of what? With the blood transfusion. Yeah, fluid volume overload. And I think that's something you'll assess during to see like what's going on, but or later. Yeah, you might need a diuretic for the CHF people or so you can give Lasix to people that have CHF that might be at risk of FPO. And generally you want to start slow first initially, then increase speed. Assess frequently. And now we can actually talk about just like the steps. Yeah, yeah, like eyes and nose and stuff. Yeah. So you guys will actually get to do the blood administration and CPE, not CPE, sorry, in Sims. Um, Although I will say it's gonna be by gravity, so that's kind of weird. But on the simulation one, it's by gravity. Well, I guess you just kind of yeah. Yeah, Ryan specifically mentioned, yeah, 60 ml per hour initially for the first, how long? Yes, you're gonna do some math on that as well. You're gonna need to know how to convert your ml per hour into drops per minute, and then divide that number by 4, and then count in 15 seconds. Yeah, first 15 minutes, 5 to 15 minutes. You're gonna want to stay with the patient, of course, and then you can increase like about 150 ml per hour. The number exactly will probably change depending on policy or hospital. Um, and Josh mentioned it before, but PRBC must be transfused within no more than 4 hours total. That's important. Okay. And then here, and here is kind of your what I have written down for your steps. So this is kind of my interpretation of the skills that you guys learned on your actual day. So I'm just gonna write them down. We'll talk about it. So we did mention that, but I'll just so we mentioned you're gonna need informed consent for the eventual receival of blood. So they're gonna have to sign. And then when you're actually going to give blood, you want to have a verbal consent if they're conscious, of course. Just to make sure that um, they're okay, they're good with the blood transfusion. You're going to make sure they have 2 large bore IVs if they're patent. You're going to want to have NS and tubing at the bedside in case of an emergency. That's separate from your Y tubing and stuff. You're going to do a urine sample just to assess, compare with the says back to lab. Yeah. Um, assess the kidneys. How are they working? Does the patient have um, CHF and stuff? Not for the urine sample wise, but just like in general, just to see if they have a risk of FPO. If the reaction occurs, you're going to get a new one to kind of compare for hemolytic reaction. Assessment of baseline 5 minutes prior. It's still a medication, so you're going to do 3 checks. You're going to need to compare the blood with another RN, so that's key. And you're going to do this for each unit of blood. Um, yeah, for hypothermia, use a warmer and stuff. Like people have mentioned, you can pre-medicate with Tylenol and Benadryl if the patient has a past medical history of a blood reaction. During the infusion, stay with the patient for the first 5 to 15, just to see if they have an initial reaction. You're gonna do it within 30 minutes of the pickup. Infuse at half the rate for the first few minutes. First 5 to 15 minutes. Vital signs again at 15 minutes, at an hour, at 2 hours, and so on. The weight gain, he mentioned specifically 2 pounds per day or 5 pounds in a week. Signs of fluid volume overload, you're going to have to call the MD for that. Patients at risk of FPO, CHF, um, ESRD/renal failure, which is like AKI and whatnot. So that's, I want you guys to keep this in mind. I don't know why it's red. This criteria will continue on for from now on. Just keep this one in mind at all times, pretty much. And then after the infusion, uh, you're obviously going to assess the patient. You're going to see if there's decreased signs of the anemia that we talked about prior, the increase in the H&H, which we talked about as well. So all of that is going on. All of that is kind of from the skills that you guys learned on Monday and the paper that you guys have on it. So this is kind of also how your Sims is going to go. In that situation, I think the consent is already done, but you are gonna want to ask, get the verbal consent. Where is it? Here. Yeah, so you're gonna make sure to do this. At some point, you should have already assessed for this. You're gonna have someone prep the NS. Prior, someone's gonna do a urine sample. You're gonna do your baseline, get your vital signs, level of consciousness, get your 3 checks. So you're gonna have one of your classmates compare the blood band, all the patient information with the blood. If you need to pre-medicate on that person, you do. You're gonna stay with the patient to assess for their reactions. If they have a reaction, then you're gonna do what we're gonna talk about in like a little bit and whatnot. So that's gonna go down in sim. So I know some of you guys were kind of getting ahead on this, but we can talk about it now, just like the reactions. So general signs and symptoms of reactions. Can you guys name some? Yeah, like an elevated temperature, so like a fever. Oops. Yeah, so what happens with the allergy or anaphylaxis? What might you have what might you feel? Yeah, like a flank pain. You can have flank pain, chest pain possible as well, I would say so. Shortness of breath. This is just general. So if you see any of these, like you don't I think you don't have to always like have them separate, all the different reaction types separate in your head. Just in the moment, just think about if I see these, I'm worried about something, right? Just kind of you can kind of cluster them, try to just cluster it all and be like, if they're having all of these if they're having any of these happening, I need to be worried or I need to do something. So just kind of cluster it all down. Um, yeah, tachycardia. So you mentioned anaphylaxis, so you can have yeah, dyspnea, tachypnea, and I'll include headache. Yeah, I think so. Maybe they get little tingling in their throat, which could be a sign of a closing airway. So that could be like an anaphylactic or allergic reaction. They can get a rash, maybe like a tingling in throat. So their airway might close. They can have chills and stuff. Pretty much just if you feel like you see or you have this happening, don't take that extra few seconds to think about the specific type of reaction. Just kind of do something. Start your interventions and you'll figure it out based on the protocol. But it just kind of think about like if I see any of these, I do something about it. And then what do we do? What's like the generally what do we want to do? What's the first thing we want to do? Yeah, so what's causing the issue? It's the infusion. So we're gonna stop the infusion first. Then you're gonna focus on ABCs. What else do you do? Like just like if you have your team, like think about like if you were in sim, what would you do? You would focus on their ABCs, you would delegate for yeah, that's a good one. RRT and call MD. I would prioritize RRT. A doctor's not going to do much for you. Yeah, you're going to want to run the NS. So disconnect the IV, disconnect the tubing, and yeah, exactly. So because you don't want to use the one that's on the Y administration set because you open that up and then the saline is going to flush the rest of the blood in the tubing in, and the blood's the thing causing the problem, so we're not going to want to do that. So we're going to want to change the tubing, um, or like DC the tubing and connect with the separate bag of NS. So I know we've had like I think conflicting how you say it, conflicting information on this. So um I've heard from some instructors they want you guys to um put the NS bolus on the same IV that had the blood, and then I've heard some say do it on the separate one. And what have you guys heard? So if I have a left and a right IV, my left is running blood. They have a reaction. Um, okay. So I remember in the boot camp, the instructor told us a different site, and then when we got the sim, they told us the same site. And I think the idea, I can see the rationale for both. The idea for a different site is that there's probably still, even if you DC the Y administration tubing, there's still a little bit of the blood left in there. So if you flush you'll get a little bit of that blood still being flushed in. Um, so if you do it on a separate, you prevent that from happening. But then now you don't have a patent IV because you're saying that the one that's separate, the one that had the blood is now unusable, and then the one that has the NS is running the NS. So now you don't have an IV. I would imagine so. I think so. And then in Sim, they told us to run the NS on the same IV, with the logic being, okay, you're pushing a little bit of that blood that's left in like that little slight, little tiny bit of tubing. That's like 1 ml that's getting pushed in. But now, by doing the bolus on that arm, you have an IV. Your IV is still on the other side is completely available for whatever you need. So there's the logic. There's logic for both ways, but in Sims, they told us to do it on the same IV that had the blood initially. So I would confirm that with with Mr. Jim and whatnot. If I recall, the need for the distinction wasn't really, man, like you didn't need to know the distinction. It was just you needed to know that you do give the NS, and knowing which site it is didn't really come up. But for Sim, it did. That's what I recall. Okay. So of course you're doing your ABCs. Um, Second urine sample to assess for hematuria due to hemolysis. Some medications they might give. They might give corticosteroids, open up the airway. Though we're doing the fluid bolus, diuretics based on whatever. So you're gonna do all that. Vital signs, of course, kind of goes with all your other stuff. Every 5 minutes, you're gonna want to document everything. You want to document start of symptoms, actions taken, how patient is doing. So kind of like in a code, you start documenting everything that's going on, what people are actually doing. You're gonna want to do all that. You can notify the blood bank as well. But again, your focus is on stopping the infusion. Um, your ABCs, of course, whatever you need to do to help them with that. DC the tubing, connect, and get the NS bolus. That's important. RRT, definitely. More hands on deck. Even if it's like a minor reaction, you never know. Your minor sounding little tingle in your throat could lead to a full airway closure eventually. So you never know. You always want extra hands on deck. And then here, just gonna quickly go through the little ones, the little specific types. So something that might put someone at a higher risk of febrile reaction would be too many blood transfusions in the past. Yeah, could be a reaction um from white blood cell the white blood cells of the recipient reacting to donor white blood cell count or the white blood cell. This one's probably the most common. Um, let's see what else we got. Signs and symptoms. So I think a lot of that comes from like your boot camp. I'll just write what I have down. I think this is also just interpretation from the boot camp. Um, so I think this part here is from our notes from like the lecture, and I think these numbers are from Mr. Milton, and I think these are Celsius. Um, so kind of there's a little disparity there between the Fahrenheit and the Celsius. I'm sure we can 0.25 T to F. Los Alamitos, that's well, it doesn't really work like that actually, now that I think about it. It doesn't you can't really do it like that. In terms of like increase, it doesn't really work. Um, because of the way the thing is. So it'd be probably more like you can see the me working on questions for um OP. But yeah, I think this is just straight from Milton. But the main thing you really want to know is that yeah, if it's like a mild reaction, it's possible to slow the transfusion, call the doctor, and then maybe give Tylenol Benadryl, and then continue. If it's a severe thing, you're gonna go through your typical reaction where you're stopping it, DCing the blood, calling RRT, running NS wide open, and some of the things we have um, directly from like the notes is like a change from the baseline. You can have chills, headache, tachycardia, hypotension, tachypnea. Okay. But just keep in mind it's going to be mostly your general signs and symptoms, your general reaction, rather than being super hyper focused on being able to tell apart the different types, which is why I'm kind of just copy pasting and top typing about it, also because of time. Hemolytic, this is when the type and cross was mistyped, so it leads to your body reacting to the antigens on the donor blood, attacking it, leading to the lysing, the destruction of the RBCs, can lead to issues with the potassium, um, issues general with your circulation. So that can, of course, lead to your kidneys. Your kidneys are always going to be something that reacts to problems with your perfusion. So you can have flank pain, chest pain. You'll have, like we talked about, that urine sample. We're going to get the urine sample. We'll see blood in the urine, or even if it's like a little bit of cold, you'll have vital signs that are similar to your shock. So the hypotension, the two like big compensatory factors, your tachycardia, your tachypnea, um, and because it's like your cells attacking the donor cells, you can have exaggerated clotting cascade, which would lead to DIC. And then, like I said, you can assess for the potassium because if you're lysing blood, that means you're releasing potassium, and you're gonna want to watch out for like the peak T waves, which is like a sign of hyperkalemia. As gonna get the EKG going, because you don't want them to have arrhythmias. You're gonna have to follow your protocols on all your arrhythmias, but for now, you don't really have to know that until fourth semester, which we'll go over how to manage the specific arrhythmias, your CPR, not the CPR, but your ACLS protocol. So what to do in the code blue. But for now, just things to think about, but again, don't have to hyperfixate on the specifics. So for your allergic or anaphylactic response, this one it's believed to be caused because your immune system is having a exaggerated response to protein in the blood that you're being given. So some of your signs and symptoms, think about a lot of airway problems. So like I mentioned before, maybe you're giving blood and a patient's like, oh, I kind of have a weird tingle in my throat. Seems minor enough, but it could be a sign that you're progressing into an anaphylactic reaction. Maybe their airway is about to close. So even if it seems minor, you still want to do your interventions and call RRT. What if their airway does close? They might need to be intubated or something. Um, if someone has like a history of anaphylaxis or a reaction like that, then you might get Benadryl prior. But generally, in an epinephrine, we know that's one of the meds, the EpiPens they give for anaphylactic reaction. But in general, it's going to be a lot of the same stuff, which is why I have the general interventions and general reactions. Easier to just cluster it all down. For fluid volume overload from rapid infusion of the blood, patients in risk of that are going to be those with CHF, those with ESRD, renal failure in general. You can give a loop diuretic after the first unit before the second. People with these, even the elderly, can be at a risk for FBO. Some of the signs and symptoms are anything you guys should be able to recognize, like crackles in the lungs from pulmonary edema, bounding pulses because of how much fluid is going through the JBD. So that's the jugular venous distension. So let's kind of take a look. This guy kind of has it. This one really has it. You can see how that can happen from having too much fluid. And keep in mind this right here, the 2 pounds in a day, 5 pounds in a week. And yeah, similar treatment to those with people with CHF, congestive heart failure. And then in terms of bacterial, if the blood is contaminated, you might be having a risk of sepsis, which is why you want to make sure that you do start within those 30 minutes and that you do transfuse it within the 4 hours. Okay. Is there any questions on blood so far? We're going to move on to your FFPs and your platelets otherwise. And then I think we'll touch a little bit on TPN. Um, anything we don't finish on TPN, um, I'll get through it on the next one. But like I said, I think that one will probably be on a Tuesday instead of Sunday, just because I have a shift today, and I will probably be asleep at 12:30 tomorrow. Okay. So the major things to know about your FFPs is what it's used for. What does it actually affect? Yeah, it's gonna affect your PT-INR, affects coagulation, and you gotta make sure clotting factors specifically. So your PT and your INR, that's gonna be key. Um, to realize that it is a different measurement than your platelets. It is very specifically your PT-INR, and just keep that in mind. That's probably going to be something you guys will get tested on in terms of not so much like you're going to be directly asked the question, but it will be like a possible like a distraction in an answer. So it's like it'll be a possible wrong answer that it that you're saying that it affects the platelets. So just keep that in mind. This is key for understanding that. So just kind of as a refresher for your PT and your INR, your PT, typically like 11 through 13, your INR, like about 0.7 to 1.1. Not honestly pretty similar number on the INR to the creatinine number, decently similar. And then it can also affect the PTT as well. So, PTT. Oh, I didn't even notice Caitlin came in here. Yeah, that's how I remember. That's how we learned it. So you guys are gonna get exposed to some of our weird ways of remembering stuff. I'm just trying to see if I have anything else that I have a weird way of remembering. I don't think so for this. I know for OB, I have a really strange way of remembering um the fundal
I
massage.
just told them about that.
Oh, you just told them about that? Oh my God, that's awesome. But yeah, for this one, I don't even know. Here, I'm just gonna it's a time.
What are you trying to ask?
I was gonna
Oh,
say, wait, not the game. Literally, like this, I saw fresh frozen plasma, and I'm like, and I don't know why it just reminded me of the scene where he just comes in and he goes pizza time, and I'm like, fresh frozen pizza time. I don't know. That's how I remembered it. It makes it makes me feel crazy, but that's how I remembered it. It's stuck in my brain.
it's okay. I just made a reference earlier to Dragon Ball Z,
Really? How?
with Rituxan, the
Pizza time.
monoclonal antibody used for the leukemias and like the process of how it works. I made a Dragon Ball reference, so it's okay. We'll make
Interesting.
it. Yep.
But yeah, that's our dumb way of remembering it. And I'll get you the PTT as well. So that's 30 to 40 seconds. This is also seconds. So remember that if your PT and your PTT are going up, like the number is increasing, is that what does that mean in terms of your coagulation? Does that mean you're clotting more or you're clotting less? Yeah, that means you're clotting at a slower rate. So you're gonna bleed more. All right. So what about ABO compatibility with your fresh frozen plasma? Does it need to be compatible? It is, exactly. So you do need it. It is needed. So keep that in mind. You do need to make sure that you're ABO compatible. And what are some examples of patients that might need to use it? I mean, bleeding is already obvious. Um, what else? Yeah, DIC, depending on what the issue is. So with DIC, um, yeah, I like that. Liver patients, depending on what's going on. I thought you don't need it to match. So for fresh frozen plasma, you do, but for platelets, you don't. But for FFPs, you do. It must be ABO compatible. Yeah, I like liver patients. That's a possibility depending on like oh, no problem. Yeah, like trauma, surgery. It depends. You're not I think this is harder. It's probably not as common to do this one compared to like blood for this, but surgery, trauma, probably possible for sure. What about as a treatment for something for an overdose. Yeah, like a warfarin overdose, you can give vitamin K, or you can try also giving the fresh frozen plasma. So a Coumadin overdose. People with DIC, yeah, like Nydia mentioned, it depends on what the issue is with your DIC. You're gonna have expended clotting factors, but you can also have microclots. So that's why you might have heard that sometimes people with DIC get heparin, because maybe if the issue is currently that they're overly bleeding, then you can give FFP. If the issue is more so the microclots, then they can be on the heparin drip. So it's a little paradoxical in that sense. But yeah, so DIC is another one. Something else that they mention is kind of like high intake of PRBCs. They say maybe like 10 units given. Essentially, the idea would be you receive so much PRBC that you diluted your clotting factors. So kind of like with your sodium, where it can be dilutional, or it could be actual loss of sodium. This would be like a dilutional um, decrease in your clotting factors, because everything in your blood and body is a percentage. It's based off concentration um, rather than like a raw number, just like a concentration value. So when you're diluted, it has an effect on those values, which is why like you're dehydrated, you can get you're able to get hypernatremia and whatnot, because you might not have gained any sodium, but you're so dehydrated that you lead there's not enough fluid to keep it as a normal level, or the other way around, your FBO, the number of salt didn't increase, but there's so much fluid that it dilutes it. So similar idea here. There's so much RBCs being given that it dilutes your clotting factors. Something else, maybe just run fast. Run it fast. Monitor after infusion for, we kind of already talked about it, so moving on. Yeah, like PTRNR. I think they say like over 30 minutes. And I think it's like 200 ml over 30, aka 400 ml per hour. But I don't think the number itself is a priority. But just maybe just run it fast. Other than that, this is priority. This is priority. You need to know that. Obviously, when you're assessing it, you're going to want to see an improvement of your PTINR. You want to see an improvement of your PTT. You want to see an improvement of your bruising and bleeding, because that's why you gave it for. And yeah, because you are giving it fast and whatnot, so you want to also assess for FBO, because you're giving a lot of stuff quickly. Just always things to keep in mind. All right, any questions on FFP? Pizza time. All right. Seems like we're good on that. And then platelets. So what is your normal range for platelets? And I know this differs between facilities and whatnot. Like, give me like an estimate. A rough estimate. Interesting. What about a low range? Like a low number? I think, yeah, listen. Oh, okay, I see where you guys are confused on. Okay, so I know it varies between facility and facility. So like I would say like a normal range is between like 150 to 400 on the computer. Yeah, like Nitty, like 150 to 400 or 450. But typically even we don't really emphasize the platelets as severely as when it goes under 100. Once it goes under 100, we're thinking about really high risk of bleeding. If they're on heparin, it could be HIT, heparin-induced thrombocytopenia and whatnot. There are some criteria that we'll use for it. I guess I understand what you guys were talking about with when it came to that, those values. But just like the normal range, like 150 to 400, less than 100, um, um, risk heavily increase for bleeding. So that's when under 100 is like when we're really like worried about it. That's like a really more critical value. But under 150, if it's 140, um, it's not good, but it's not like super bad, relatively speaking, compared to like when it's under 100. We talked about this, so ABO compatibility is not needed, but it's worth keeping in mind. If there is incompatibility, it will be less effective. You're not gonna have a terrible reaction, but your platelet count might not increase to the same amount as it would have if they were matching. So then who receives it? Here, this is where you guys were talking about some of the ratios. So obviously someone that's actively bleeding, it makes sense that they would get platelets. I think Ryan mentioned, so I saw like less than 50, I saw less than 20. So less than 50 if they're symptomatic, less than 20. And this is in K, but typically on the computer, you'll just see it as like 150 or you'll see it as 400 um, for the units. So in this case, you'll see on the computer 50, and this on the computer you'll see as 20. So yes, exactly. So less than 50 if you're symptomatic, aka you're bleeding. Less than 20 if you're unsymptomatic, because that's a horrible number. Surgery with less than 100, that's a value you're going to want to tell the doctor for sure. And of course, we're going to want to monitor after infusion, just improvement of platelets, improvement in symptoms. All right, what makes sense? Stuff that makes sense. Less bleed, the gums are not bleeding. There's less bleeding at the IV site. Um, the numbers don't focus too hard on them in terms of the increase in platelets. You don't have to hard memorize the number, but it's um, just there for your knowledge. Stuff like this you can easily rationalize, but in this you don't have to focus on the number. You just focus on these numbers, like understanding the normal range and understanding some of the criteria for it. So probably priority here, and understand that this affects the platelets and not the PTINR, and then likewise, or opposite, vice versa, this affects your coagulation factors, not your platelets. So don't get caught on that. He will ask a question that will try to catch you on that. Just don't get caught. Okay, any questions on those two? We'll do just a little bit of TPN, as much as we're allowed the time with, and then I'll finish it off and include that and also your hematology on Tuesday. I think I'm gonna do it on Tuesday. And it'll probably be Tuesday at like 6 p.m. or something. And we can go up until I think the Student Success Center is open to like a decently long time until 9. So yeah, we have plenty of time if I start at 6. And that gives me time to sleep. I'll probably be awake. I'll probably wake up on that day at like 4 p.m. or something. Oh boy, this night shift's crazy. Kaylin, do you know if you're night shift or day shift yet? I think you're day shift though. Lucky.
Oh, we've talked about this before. I got day shift.
Yeah, you're day shift and you got the unit you wanted to go into. Lucky. Okay, so there was no questions on it. Some of you mentioned this already when we were talking about central lines. We talked about hypertonic solution, hyperosmolar solutions for being an indication for the central line. So your TPN is one of those hypertonic solutions, nutrient solutions that will be given through a central line. So just keep in mind that with a TPN, you want central line. You technically can run TPN for like a little bit on a peripheral line, but it's not something you want to do. If you guys had your boot camp on the first day with Miss Pison, I think she had an anecdote. She probably had like an anecdote about, oh, Hively took it over. Oh, okay. So for us, we had Pison, she normally does pediatrics and also third semester at Whittier. But she has like an anecdote where like a baby was receiving TPN on a peripheral line, which is fine for a little bit, but there was some amount of negligence going on, and due to that TPN running on that peripheral line and extravasated, and that baby had to get amputated. Like their arm had to be amputated. It was necrosed, or whatever limb they used. It had to be amputated. So keep that in mind. Don't amputate the babies. All right. So TPN enteral versus parenteral. Enteral means using the GI tract. If you had to choose one or the other, what would you do? Which one would you choose and why? Yeah, you want to keep an active gut. And we'll talk a little bit about why you want to do that, but GI tract is preferred. What is GI tract is preferred if possible is enteral for multiple reasons. Yeah, exactly. So it's going to be safer, more cost effective. You want to use, again, like Josh said, if you use it, you don't use it, you use it, or you get some complications based on it. So it is preferred because you have some complications with TPN, which is your parenteral. So some of the things that we talked about, um, you're using TPN, so you're using a central line. So it includes CLABSI due to need of using central line. So if someone needs a central line just so that they can start TPN, then you're also having to manage a central line, which means CLABSI, a risk. We want the blood flow can eventually overgrow. Yes, so you can have that bacterial translocation, and that can lead to sepsis. That can lead to um, probably like peritonitis. So lack of enteral. I kind of have like this little thing here. And what do you pre-medicate to prevent that if you are on TPN though? Yeah, Flagyl. That's metronidazole, if I recall. So here's kind of like the concept. You don't have to hard memorize this. This, for me, makes it easier to think about why this is happening. So lack of enteral feeding, you have atrophy in the mucosa of your GI. That's going to lead to an increase in the permeability of your intestines, meaning things can kind of like translocation. It can move from where it is to a place it's not supposed to be in. It can cause an overgrowth of your flora, of your gut um, biome. All of this can then lead to infection and sepsis. So just like Ryan mentioned, you can pre-medicate with Flagyl PO for prevention. Okay. So then, did I mention for who it's for? I mean, it's kind of makes sense for who it's for. I guess we'll do here. I hate when that happens. Okay. Who is it for? People who are people where the enteral route is impaired. I'll see if I can try to get up to here. Okay. Because at the very least, I want to talk about the contents of the TPN. Because I know we're gonna have a lot of people stressing out over it. So I want to get that going before having to shift to Tuesday. So it's for the Antero riders impair MPO for a long time, so maybe 7 to 10 days. So some conditions that might lead to them being MPO um, could be like something where it causes you to rest the bowels, maybe like a pancreatitis or something, cholecystitis or something. Cancer as well, yeah. So some examples. Let's see. I have a list of examples. Um, don't hard memorize. Just kind of get the general idea. Eek. That's probably better. And there we go. So some examples that I have written here: people with malabsorption, malnutrition, hypermetabolic state. So what can that mean? Maybe someone that's having um, an aggravated case of hyperthyroidism or something that makes their body go into a hypermetabolic state, overworking the body, MPO for a long time. So we mentioned this. Lost more than 10% of pre-illness weight, paralytic ileus, Crohn's disease, so bowel obstructions, severe burns can be on TPN. They might not have access to the ability to eat, and they might not, depending on where they're burned, they might not be able to use the I guess they should still be able to use the GI, but kind of a thing that they mentioned. They have to be MPO for a long time. Chemo, but also you wouldn't want to, or whatever. We're just moving on. Just severe burns. You'll learn more about burns in 240. I'm just rationalizing it with the knowledge from last semester. Um, all of these things. Again, don't hard memorize anything. Just kind of logic it out. So then we talked about this. So then I just want to talk about the contents real quick because there's a lot of contents mentioned and you don't need to know all of it. You just need to know the key aspects of it. So amino acids, when it comes to proteins, this is proteins. What is your important thing with it? Can anyone think about the thing he mentioned specifically? Um, yeah, you want that positive nitrogen balance. You want to maintain a positive nitrogen balance, which essentially means that you have, yes, exactly. You have enough protein um, available so that your body isn't wasting muscle, which is a similar reason why they might give D5 IB fluid. So the D5 is in theory enough sugar to maintain enough energy so that the body doesn't muscle waste as much. So that's like the rationale between like why some people might be given D5 half an S as a maintenance fluid because the D5 helps to prevent them from muscle wasting. But in this case, the TPN, those proteins, those amino acids are having that same effect, maintain a positive nitrogen balance, which is half more protein available than being used in the body. What's it called when you're having muscle wasting? Like the medical term. Rhabdomyolysis is like the direct, like the breakdown of muscles. Um, like I'm not thinking of rhabdomyolysis. I'm thinking of like the term for muscle wasting, not like a muscle breakdown in the same sense of rhabdomyolysis, but just like yeah, muscle wasting from weight loss and poor nutrition rather than from like a pathological sense. Rhabdomyolysis is kind of like a quick, fast, acute destruction of muscle. Um, Kinda. It's not trophy. Okay, so it's called cachexia. So again, the thing I hate the most in nursing school is when um they hit you up with a medical word for a term you know, and then you're like, I don't know what that is. And then you get like screwed over for no reason. It's like I know what I'm looking out for, but I just didn't know that specific word. So cachexia is the word for muscle wasting. Yeah, so just keep that in mind. So you know if it comes up as a question or an answer choice, you know what it means. You know what it's referring to. So carbohydrates, obviously this is for energy. Um, and also you need it for energy and need it also to prevent a negative nitrogen balance, kind of like we talked about with the getting like D5 fluids. You're giving them the glucose, so their body has sugars and carbs to use, so it doesn't have to resort to muscle wasting. So it's a combination of the carbs and the combination of the proteins, the amino acids that are going to keep us from muscle wasting. And obviously you need carbs um, for that. So just kind of know the amount of dextrose in the TPM bag. Typically, what is it? 3 minutes. Oh, that's 3 minutes until the end. Yeah. Yeah, 10%. Excellent. Lipids, what are we using them for? Um, it's used for a whole bunch of stuff. Calories, yeah, all that stuff. Don't worry about that. It's okay. It's okay. Um, the main thing I think to think about, yeah, there's a lot of stuff there. It's good to know, but these are yeah, like yeah, it's used for like cholesterol and stuff. It's okay. Shh, it's okay. Just understand that when it comes to like the lipids, they can be hung separately for the rest of the TPN. Um, the main thing is that you're infusing them every 12 hours. So the bag for the TPN for lipids is every 12 hours, which is different from TPN, which is done every 24 hours. So you might hang if for some reason the patient needs it, they might um get two lipids hung because it's every 12 hours. But here it gives you like a lower time frame here. The main thing is that it uses a lot of egg product, so if they're allergic to eggs, they can't receive lipids. Just do not filter them because it might clog. Don't worry about the whole thing with the filters. It's not, it's fine. You'll be okay. Complications, maybe just look for fat embolism, um, triglyceride spike, like call MD if they spike. That's kind of in the name. Fat embolism, very similar to like pulmonary embolism signs and symptoms. So dyspnea, chest pain, altered level of consciousness, all that stuff. So now your H2 blockers, I guess we don't have too much time. Just examples of H2 blockers, famotidine, right? Anything that ends in dine. Um it's like ramatadine, is that a one? If it ends in dine, is this actually did I actually memorize the name of this? Ranitidine, close enough. Pepsid, yeah, I think Pepsid is famotidine, yeah. So that's Pepsid. Why do we use it? We use it to prevent gastric ulcers. Cool. Water, minerals, electrolytes. Notice that I did not I know he had a lot of stuff on this. Uh, it has this in the thing. Just know it's in there, and you're good to go. And sometimes you can have insulin. What kind of insulin would be included in an IV solution? Yeah, regular only. So he likes to catch people a lot on, yeah, also important to note sometimes, not always. It's important for you to know what's in your TPN. So what does that mean? You need to know if there's insulin in there, is there heparin in there, how much dextrose is in there. That's the most important things to know. Um, Yes, exactly. And we'll talk more about that, I guess, on Tuesday because we're running out of time. But the key thing, yeah, I know it's okay. We'll be okay. So it's just important to know what's in the TPN and to monitor for labs. That's important. So I'll include that here. Regular only. So he loves to catch people on like writing an answer where it's like give insulin IV, and that might be the correct choice, but he'll put like MPH, and it's like, oh, gotcha. But yeah, just keep in mind regular only. And then sometimes they give heparin. Sometimes, again, keyword sometimes, not always. Sometimes. It's just important to know what's in your TPN, but don't stress too much about the contents. I know I did, and it didn't pay off. The main thing is probably what I have listed is probably gonna how much. Oh, dude, yeah, that's funny. Talking about the math question, yeah, and that sneaky guy, he made the answer 420. Isn't that crazy? 4.2, 4.2. All right. Oh, I guess that's already in there. I guess I double mentioned it because yeah, the goal is for that. There's a few other goals. We'll talk more about this. Um, but this is where we're gonna leave off. So I will we left off here, and I will do this, and I'll give this to you guys. So you guys have something to look at. We will fill the rest of this out and go with hematology as in your leukemia and whatnot. And for some of you guys, that's review. Um, I broke it down into a very generalized thing. What class is this? 232. Okay, perfect. Yep. I know. Yeah, and good luck with that. Yeah, thank you. I know. All right, there you guys go. You're free to go. We'll leave off. We'll continue on Tuesday. And yeah, hopefully also along with everything we talked about, the charts, the pictures, they come in handy. And we'll get through 232 together. We'll work on mock scenarios. We'll get to 240. We'll we'll yeah, we'll make it to Shell City, save the Krusty Krab or whatever. We'll make it. All right, bye-bye. All right, let me know if you guys have questions, Jade or Nydia. If not, we gotta go before they kick us out.